There's actually two big reasons why to keep the supportive care optimal and also the chemo and the radiation schedule optimal in order to avoid side effects. First of all, because it's humane to avoid side effects. And second, patients should be in a very good condition to be able to receive immunotreatment afterwards. First of all, I think we should start with supportive care before side effects occur. So that means quit smoking from the moment that the patient receives the diagnosis of lung cancer. That is the moment, at the same time, literally at the same time, to discuss quit smoking, so smoking cessation program, to discuss nutrition, and to discuss physical exercise. Because you try to avoid this type of conversation in order to spare the patients, but it has been shown that it's just reversed. You should really keep the opportunity, take the opportunity to discuss this, because then you have the highest likelihood, not only that the patient will change the way of living, but also that he will keep on doing this for a long time, even after 1 or 2 years. So it's a kind of crisis intervention. You should not wait until after the crisis. You take the opportunity, then you have the biggest chance for success. So it should start before, and it's also important, I think, to have a dietitian directly involved in those patients, because the food is so important, taking into account protein intake, taking into account that a lot of patients don't have healthy food habits. Smoking cessation, I already mentioned, and then also physical exercise, not necessarily walking or biking or so, but also some fitness, and possibly also with a physiotherapist. So that's where it all starts. Then, from a technical point of view, stick to the ERTC guidelines, for instance, for the technical delivery of radiation, to avoid the dose to the normal tissues as much as possible. That's more the technical published ones. And then during the treatment, apart from dietary advice, also painkillers, treatment of infections, also of the esophagus. All of this is important to have the patients in the best shape as possible. And we have now a project with ESTRO and ESMO together, so the two European societies together, which will be launched at the meeting of the ESMO in Munich this year. And there we will come with evidence-based supportive care measures for patients receiving concurrent chemoradiation. The European guidelines for supportive care during concurrent chemoradiation are new because there's no guidelines specifically in this case, so that's really a lack. And what we did is actually looking at the 3 pillars for supportive care, so smoking cessation, nutrition, also physical exercise, and we looked also to some technical points, but we looked also what is the evidence. If they are involved, what would be the effect if we do a certain intervention? And for the future, more importantly, we define some knowledge gaps where there's more research needed in order to close the gap, of course. But the guidelines will be very practical. So basically, I think that everybody involved in lung cancer care, including the patient themselves, will be able to read it. And even though the background will be quite, let's say, specialist care, but the recommendations are very clear and something what everybody could do. For instance, it will be written down that you should do at least 20 to 30 minutes of physical exercise a day, which includes walking, for instance, or some basic fitness. That's one possibility. Or 1 to 1.5 gram protein a day, something like that. And of course, when it comes to the technical guidelines, we refer to the published ones before. For the community radiation oncologists, I believe that it's important to stick to the published guidelines. So really stick to the guidelines according to techniques, how to delineate organs at risk, how to prescribe the dose, that's more technical, how to calculate which algorithms should be used. This is really important on the one hand, and on the other hand also take into account the systemic treatment, because some systemic treatment cannot be given with radiation, like gemcitabine as an historical example. That is, I think, the most important message, I would say. Stick to the current guidelines, technical guidelines, which drugs to be used, and also which supportive care to be used. Don't say, well, it may work with a little bit difference because it's more practical, because you never know at the very end of the day what will come out of it from the point of view of toxicity and even survival. I'm convinced that the awareness on keeping the patient in a good condition has indeed increased by the availability of durvalumab after chemoradiation. Because everybody of us wanted, of course, to keep the toxicity as low as possible and as short as possible. But now that we know that there's a drug available which indeed, beyond any doubt, increases the overall survival of patients, but only can be administered in patients with a good general condition, the awareness is indeed increased to have the least possible side effects and to increase also supportive care. And that is actually a very important and very positive spin-off beyond the immune effect on itself.